Hello and welcome to Triage, timely conversations for healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
Welcome to another episode of Triage. My name is Gabe Scott, and I'm a healthcare partner in K&L Gates healthcare and FDA practice. Today, we're talking about a big upcoming change in accountable care, the new ACO lead model, which replaces ACO REACH. And given that there are several developments that are really new features in the ACO lead model, this episode will provide a quick background on that model and then focus on what we view as being the 5 key issues as ACOs and providers consider participation. To do this, I'm happy to be joined by 2 attorneys, Kevin Alonso, who's a partner, and Kennedy Caldwell, who's an associate, and both of whom practice from our firm's Nashville office. Welcome to you both, and thanks so much for joining us today.
Thanks, Gabe.
Thanks for having us.
So, Kennedy, let's start with you. What is the ACO lead model, and what is CMS trying to do here with this new ACO model?
Yeah, so LEAD is short for Long-Term Enhanced Accountable Care Organization Design. It's CMS's next iteration of the ACO model, and it's taking over once ACO REACH wraps up at the end of this year. The big picture is that CMS really took what worked and what didn't from the previous REACH model and used that to build LEAD. And I think more than anything, it just signals that CMS sees accountable care as something that's here to stay and not just a temporary experiment.
Thanks, Kennedy. So, Kevin, we talked about identifying sort of the 5 key issues to consider. The first of those, I think, is that there are really some key differences here between the ACO REACH model and LEAD. Can you tell us a bit about those?
Sure. So REACH was really a short-term pilot. It only was meant to run for 4 performance years. LEAD has a 10-year performance period, which is the longest that CMS has ever tested in an ACO model. This should give ACOs time to make care delivery investments, build infrastructure, and then actually see a return on those investments. Also, one of the big complaints with REACH was that benchmarks were periodically rebased, creating a situation where cost-efficient ACOs could be victims of their own success. Through rebasing, those ACOs would need to beat ever lower benchmarks to earn savings in subsequent performance years. LEAD does away with this rebasing entirely, which should provide welcome stability to participants over the next decade.
Right. So in addition to dispensing with rebasing, LEAD also sort of takes a different track with regard to high needs patients. So we understood that REACH had a dedicated high needs track for patients with complex needs. Kennedy, I think LEAD does something different with that. Is that correct?
Yeah, so that's definitely one of the bigger changes in LEAD is that it gets rid of the separate high needs track altogether. So instead of carving those patients out, CMS is building high needs support into the model for all ACOs. So pretty much every participating ACO gets additional tools and support to care for high needs beneficiaries, not just the ones that opted into a special track like under REACH. But LEAD still keeps a lot of REACH's technical approach, things like benchmarking, trend factors, and concurrent risk adjustment. But the idea is to bake those policies in across the board. And it seems that CMS's hope is that this makes caring for high needs patients more feasible for more ACOs. But I think most importantly, ACOs that really specialize in high needs populations will still get flexibility, such as lower beneficiary alignment minimums.
Kevin, we've heard some discussions under the LEAD model about Medicare and Medicaid integration, which would be a substantial difference. Can you tell me a bit more about that?
Yeah, so most providers are probably familiar with dual eligible special needs plans under Medicare Advantage. Nothing like that currently exists for dual eligible beneficiaries in original Medicare. CMS will start with a planning phase involving 2 states, one a fee-for-service Medicaid state and the other a managed care state. CMS and those states will work to define how the ACOs and the Medicaid organizations can collaborate, coordinate care, and share in savings to improve outcomes. If they find that the planning phase is successful, we could start to see ACO and Medicaid partnerships form initially in those 2 states.
That's certainly a new development. Apart from Medicaid integration, are there other notable changes to how ACOs are compensated under LEAD?
Yeah, there are. So LEAD keeps the same risk sharing tracks that were available under REACH. It also keeps the familiar primary care capitation and total care capitation payment options that were available under REACH. For ACOs that select the primary care capitation option, they will now also have an advanced payment option that is similar to the one currently available under REACH, and a new non-primary care capitation option. The difference is that the advanced payment option is reconciled against fee-for-service billing, while the non-primary care capitation option is reconciled only against the total cost of care. Furthermore, certain higher cost ACOs will be eligible for additional add-on capitation payments.
Kennedy, one of the pain points for many ACOs under REACH was contracting with specialists as preferred providers. Is CMS doing something differently with LEAD?
It is, and this is definitely one of the interesting parts of LEAD. So for ACOs that choose the global risk option, CMS is rolling out something new called CMS administered risk arrangements. So the idea with this is that ACOs can bring specialists into episode-based risk arrangements, but CMS would actually run those arrangements on the ACO's behalf. We don't know a lot of details yet, but the goal is to take some of the administrative burden off of ACOs and make specialist engagement a little bit easier.
Kennedy, Kevin, this has been a great conversation. Kevin, in terms of further developments on the ACO LEAD model, what's next?
Thanks, Gabe. CMS recently released its request for applications on its website. ACOs that are interested in participating in the LEAD model have until May 17th to submit an application.
Well, thanks to you both for your insights here, and thanks to our listeners for engaging with another episode of Triage. If you have questions about the ACO LEAD model or other healthcare related questions, please reach out to Kevin, Kennedy, or your typical K&L Gates attorney. Until then, we will keep our eyes on further developments on the ACO LEAD model, and we will update as new developments arise. Thanks so much.
Thanks again for listening to Triage, timely conversations for healthcare professionals. New episodes are available for download through Apple Podcasts, Google Podcasts, and Spotify. By subscribing to Triage, you will receive timely notifications for each new episode. Also, if you have any topics you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.